microembolism, it is anatomical obstruction. It can also be because of mediators. Once there is obstruction, there will be release of mediators which cause thromboxane A2 and serotonin to get released. And there is also a role of hypoxic pulmonary vasoconstriction because of VQ mismatch. There will be hypoxia which precipitates which causes vasoconstrictions. So all this cause increase in pulmonary vein vascular resistance and pulmonary arterial pressures to go up. Because RV is more sensitive to pressure, it can handle a little bit volume, but the RV is, because it is not used to, it is used to low pressures. It is used to low pressure circulation. It is not used to high pressure circulation. Once the pressure rises, RV is not used to it, it goes into failure. And once the RV is not able to contract, RV dilates, and this causes shift of the interventricular septum towards the left, hampers the movement of LV uh, diastole as well as output, which causes low left ventricular output, which can cause sudden shock, and then there will be cardiovascular collapse. So this is the simple pathophysiology of acute pulmonary embolism. So whenever we are talking about pulmonary embolism, it is usually thromboembolism, which the thrombus usually originates in the legs or in the pelvic vessels. So when we need to discuss about workout triad. Without talking about workout triad and DVT, the talk of acute pulmonary embolism is not complete. So workout triad needs three things to happen. There should be stasis of blood, there will be some amount of vessel wall injury and hypercoagulability. All these overlap each other, complement together to form thrombus, which migrates up into the pulmonary circulation. So let us discuss about the risk factors which can cause acute pulmonary embolism. Whenever we talk about acute pulmonary embolism, risk factors involved are prolonged immobilization. Patient is immobilized either because of recent hospitalization, he has undergone a surgery, he has undergone polytrauma, patient is pregnant, patient may be in sepsis, heart failure, patient is not mobilized well, or there can be atrial fibrillation which dilates the atria and leads to stasis of blood in the atria,
sorry to
which can
interrupt.
cause embolization.
Hello.
There will be the malignancy also predisposes to thrombosis. Previous history of pulmonary embolism and DVT are independent risk factors for patients developing thrombosis. Genetic causes like factor V laden causes, protein C and S deficiency, all these things also contribute. Other causes include diabetes and obesity, which are lower odd risk factors. So whenever we speak of acute pulmonary embolism, we need to have some clinical predictors. There are some few scores which have been devised to tell us, is there a pulmonary embolism likely or less likely. So the most commonly used is well scoring, which takes into criteria parameters like clinical signs or symptoms of DVT. If there is a clinical signs and symptoms of DVT, the points are ascertained like 3. The P is most likely diagnosis. Once again. Hello? Huh? Is it? Is it visible now?
No, sir. Yes, sir. Now it's visible.
So whenever we speak about acute pulmonary embolism, we need to understand there are few scores which have been designed to tell whether PE is likely or less likely. So the criteria which are involved is whether the patient has clinical signs and symptoms of DVT, PE is most likely diagnosis, tachycardia, the patient has heart rate of more than 100, whether there is immobilization or surgery in previous 4 weeks, previous history of DVT or PE, hemoptysis, active malignancy. So these criteria are ascertained some certain points. And if the point is less than 2 points, the possibility is low risk. If it is 2 to 6 points, it is intermediate risk. More than 6 points is high risk, and more than 4 points, that it is more likely P is possible. The other more important, another important scoring system is revised Chimneva score, which has been like used extensively. So what this uses is risk factors like age, previous history of DVT or PE, surgery, active malignancy, symptoms like unilateral lower limb pain or hemoptysis, clinical signs like tachycardia, pain in the lower limb. So, and it ascertains degree of probability of PE. If the score is between 0 to 3, it is low risk, 3 to 10 is intermediate, and more than 11 is high risk. So these are the scoring systems which have been used to analyze whether the patient might be the chances of him probability of him having pulmonary embolism. Coming to clinical presentation, how does the patient present to us? We need to have a strong degree of suspicion whenever we see such patients. Patients may present with dyspnea on exertion, or he may present with dyspnea, breathlessness, chest pain because of the pleuritic chest, where the which part of the lung, if it is not perfused, well, patient can develop pleuritic type of chest pain. When patient can, because of the hemodynamic compromise, they may develop with syncope, or the patient can develop tachycardia, tachypnea, which is not usually explained by other things. You're giving oxygen, but to the you see the chest X-ray. Chest X-ray looks okay, and but your patient is needing a lot of oxygen to maintain saturation, which is not explained, and he has got a tachycardia. So we have to suspect whether the patient has pulmonary embolism. Patient may have raised JVP. Patient can have symptoms of DVT, and sometimes the patient has risk factors and he has a sudden collapse. Then you have to suspect the DVT, which leads on to PE. So once we have a strong suspicion, we need to have act fast to have diagnostic approach, a proper diagnostic approach. So we need to develop a high index of suspicion whenever the patient presents like this, and we have to get a SOV panel. SOV panel will help us to know the troponin levels as well as myocardial levels as well as BMP. So all these things are better known. Get an ECG done, get an echo done. Echo, what the classical features of echo is RA and RV becomes dilated. RV becomes dilated. There will be tricuspid regurgitation, and RA also becomes dilated. You can see the RV in the upper image. RV is dilated, and it is the interventricular septum is pushed to the towards the LV, which is causing left ventricular output compromisation. So there is one more sign called as McConnell sign, which is usually evident as the mid portion of the RV is bulging out, whereas the apex is coming inside. That is McConnell sign. So whenever we do a echo, the latest American Echocardiographic Society tells us that we need to focus the RV in RV focused view, and then only say RV is how's the RV. And if you take the ratio of RV by LV, if it is more than 1 or zero point 0.9, then it suggests RV dysfunction. Tab C, if it is less than 16, suggests there is RV failure going on, RV dysfunction and RV failure. So these are the features that we see on a echo. So there is a concept called as RV and pulmonary artery coupling. So whenever the contraction of the RV has to coordinate with the pulmonary artery for optimal output of the from the RV. So RV-PA coupling assesses how effectively the RV adopts its contractility to match pulmonary artery afterload. So normal coupling ensures energy efficiency, blood flow. Uncoupling signals RV strain. Whenever there is uncoupling, the RV gets strained. So how do we clinically assess it? Tab C by systolic pulmonary artery pressure ratio gives us if the values are more than 0.3 to 0.4, it indicates preserved coupling. The lower ratio predicts that the uncoupling is happening, and early uncoupling flags high risk cases which need that means to say these patients need advanced cardiovascular support. We have to be careful about it. Coming to ECG, the classical presentation is S wave in lead 1, Q and T wave in lead 3. So S1, Q3, T3 is the classical presentation. If you can see, very few cases you can actually see this. You can also see RVBP pattern, that is M and W pattern. So what does this RVBP pattern indicates? This whenever there is an RVBP, that means RV is strained significantly. That means to say there is a significant pulmonary embolism, that is central pulmonary embolism has happened. Whenever there is an RVBP, there is fourfold increase in chances of RV dysfunction. And once you thrombolize, you can see the reversal of RVBP with the treatment. That means to say patient has responded well to the therapy. So how do we confirm? The confirmation is if you get a D dimer. D dimer is has negative predictive value. That means whenever you suspect a pulmonary embolism, and by all your criteria and scoring risk factors, if you feel it is the likely chances of P is less, then you get a D dimer done. If it is negative, then there is no need to proceed with other tests. So most likely it rules out pulmonary embolism. Then the other test, if it is positive, doesn't confirm the presence of pulmonary embolism. BNP and troponin tells us the RV is strained. There is a strain on the right ventricle. So we have to be, and this predicts the possibility of RV dysfunction. So we have to be careful about this. And patients is categorized little higher grade if these enzymes are positive. CT pulmonary angiogram shows us there is filling defects in the pulmonary artery. So this is considered as the gold standard diagnostic test for pulmonary embolism. You can see in this picture a CT which shows pulmonary artery. There is a filling defect in both right and left. A thrombus is extending both sides. So this is a saddle. This is called a saddle thrombus. When we don't have CTPA, we can go for echo and DVT ultrasound confirmation. If both are there, then there is high chances that these patients has pulmonary embolism. If the patient is pregnant, where you cannot do CTs, then you can go for lung scintigraphy study, which matches ventilation and perfusion and tells us the possibility of pulmonary embolism. The other test for DVT is compression ultrasonography, where the presence of thrombus doesn't allow you to, the compression won't be positive. So next, coming to risk stratification, we have certain scores to stratify how risky the patient is falling into. The commonly used and exam favorite question is pulmonary embolism severity index. Helps to us to stratify the risk of morbidity and mortality and complications involved. If there is 30 to 50% of the cross-sectional area of pulmonary artery is blocked, then we call that is a severe pulmonary embolism. European Society of Cardiology prioritizes hemodynamic status and RV function via echo and biomarkers to say whether the patient is high risk, intermediate risk, or low risk pulmonary embolism. High risk, any patient is hemodynamically unstable, that is systolic BP of less than 90 mmHg. Any patient having hypotension is considered as high risk patient. Patient with RV dysfunction without shock is intermediate dysfunction, intermediate high risk patient. Patient with RV dysfunction with the troponins positive is intermediate high, and without trop positive is intermediate low, and rest all fall into low risk factors. These slides have been prepared before the new guidelines of 2026. AHI guidelines have been come in the latest circulation, which has been published. So earlier we used to do like this. The 2026 latest guidelines characterize this pulmonary embolism in a different way. We will touch upon this later on in the subsequent slides. So this is the PESIS scoring. On the middle, you can see the original version. The extreme right, you have the simplified version. So if you're these are the parameters: age, sex, cancer, chronic heart failure, pulmonary diseases, tachycardias, hypertension, tachypnea, temperature, altered mental status, oxygenation. So all these things are given scores or points. And if the class 1 is, if the points are less than 65, it is low risk of 30-day mortality, that is 0 to 1.6%. Class 2 is 66 to 85 points, low risk, low mortality risk. First, class 1 is very low. Class 2 is low mortality risk, 1.7 to 3.5%. Class 3 is 86 to 105 points. Moderate mortality risk, 3.2 to 7%. Class 4 is 106 to 125 points. It is high mortality rate, 4 to 11%. Class 5 is more than 125 points, high mortality risk. So we need to know about PESI scoring. So whenever we know the patient, we have categorized him, we know what risk he falls. We have to manage these patients. Management, unstable acute phase. When the patient presents with instability, acute phase, we need to, in the hospital, we should have a PERT team of doctors, which involves pulmonologist, intensivist, anesthetist, emergency physicians, cardiologist, all these department wise, a team of doctors, pathologists. So we have to constitute a team of doctors and form per team so that the team is well aware of timelines, guidelines of managing pulmonary embolism. If the patient is unstable or falls into high risk category or comes into class D or class E of recent guidelines 2026, then we need to consider advanced therapies like systemic thrombolysis. If the oxygen saturation is more than 90, we have to maintain the saturation of more than 90%. We need to avoid hypoxemia. We need to avoid hypercarbia, because hypoxia and hypercarbia are known to worsen the hypoxic pulmonary vasoconstriction, which can worsen the RV dysfunction. So we need to give oxygen. We have to consider non-invasive ventilation if the carbon dioxide is high, HFNO, and if the patient is unstable, consider invasive mechanical ventilation. If the patient's hemodynamics is still further worse and compromised, then consider VA ECMO. We have to institute or alert ECMO team. Coming to management of mechanical ventilation, whenever there is shock in a patient with pulmonary embolism, it is because of RV dysfunction or LV dysfunction, or sometimes rise to PVR can be worsened by PEEP. If we have, if the patient develops shock after intubation, it is usually because of worsening of RV dysfunction, because of rise PVR, because of high PEEP or high tidal volume that we are delivering to the patients, and also consider the effect of sedatives that we would have given to patients for uh, putting the patient on mechanical ventilation. So whenever we are ventilating these patients, we need to consider, are we protective mechanical ventilation? So what are the things we have to be careful? We have to use tidal volume, low tidal volume, high tidal volume increases the, moves the west zone up. So use, it increases the pulmonary vascular resistance and pulmonary artery pressures. So use tidal volumes which are low, maintain a plateau pressure of less than 30 centimeters of water, because if the plateau pulmonary pressures go low or moderate peak, do not use high peak because it increases PVR. And as soon as possible, if possible, we have to consider VA ECMO, which doesn't stress the lungs much. It is a short-term rapid support can be given, which supports both heart and the lung. So if the patient develops RV failure, the this RV failure is the principal determinant of mortality. So we need to manage this. RV protective strategies include, we need to give optimize RV preload. We have to have adequate preload for the RV to RV output to happen. But at the same time, we have to prevent RV getting too much distended. So we need to balance out RV preload, loading versus diuretics to unload. So we can use uh, ultrasound focus to know the IVC diameter, how's the RV working, and then optimize loading versus unloading. RV afterload management, we can use pulmonary vasodilators like inhaled nitric oxide, sildenafil, which is a phosphodiesterase inhibitor. Iloprost is a prostacyclin analog. So all these things can be used, but there is a risk of systemic hypertension which can worsen again the shock. So to improve the contractility, you can use inotropes, norepinephrine, dopamine. All this can be improved to used to improve RV output. Milrinone can be used. Levosimendan, which is a calcium stabilizer, that also can be used. And we need to ensure that the systemic hypertension is not worsen much, and balance the RV contractility. Coming to special situations, the patients may present with cardiac arrest. We have to, while doing CPR only, we have to consider, think of thrombolysis and consider thrombolysis in very high risk patients. Pregnancy, we cannot use vitamin K analog anticoagulation. We have to consider low molecular weight heparins. Renal failures, we have to avoid unfractionated heparins. These are the special situations we have to be aware of. So this is what I was telling about. This is the latest guidelines which has come out, which has been published in circulation. This is a very good summary of all the things related to pulmonary embolism. If you don't have anything to read, at least read this fully so that you will be able to understand, and there is nothing much left out to be read in pulmonary embolism. So all the slides I had felt it even before this is been published. I have incorporated these slides to tell the how the management has now been updated. So the new 2026 AHA-ACC guidelines have categorized pulmonary embolism into A to E classes. So class A is subclinical category, or it is also called as A is for, you can think like asymptomatic. This has been incidental finding. The scan was done for something else and it picked up pulmonary embolism. So these patients can be managed on OPD basis or home because they are not symptomatic. Class B is low severity category or low risk category. These also patients can be managed, triaged and managed in the outpatient. The SPECI score falls less than 65. In that you have B1 and B2. B1 is subsegmental thromboembolism. Patient is symptomatic, but the clinical score is low. The PESI score is less than 65. And there is possible avoidance of anticoagulation. Class B2 is little proximal thrombosis. Patient is symptomatic but low clinical score. So these patients are symptomatic but low score, and they can likely go home and can be managed on OPD basis. Class C is complicated cases. These are the patients who are complicated. They need to be admitted, monitored, and managed. So these patients have elevated clinical severity based on PESI score more than 65, but they have stable hemodynamics. They have thromboembolism, PESI score is high, but they are stable hemodynamics. This C is being classified into C1, C2, C3. C1 is normal biomarkers. C2 has one marker high. C3 has either troponin or BNP, both high. So C1, C2, C3, the key criteria is RV dysfunction. We have to use echo or CT, and cardiac biomarkers we have to do troponin or BNP. So we have to see this, and see for complicated or elevated risk, we have to manage them with anticoagulation, and we have to identify if they worsen. Class D is incipient failure. Category D, that is cardiovascular cardiopulmonary failure, has to be anticipated. These patients can be normotensive or shock or transient hypertension these patients can have. So D is for danger. We have to monitor them for any worsening of RV dysfunction, hypertension, systemic hypertension. So key criteria is they can have markers of hypoperfusion like lactates more than 2, acute kidney injury, altered mental status. So you have to be careful and pick them up early. So D1 is transient drop in BP, and later on BP improves. D2 is these patients can have normotension, but BP is normal, but they have features of shock like lactates gone up, mentation is altered. But if you say measure the BP is normal. So these D and E, we have to consider advanced therapies like systemic thrombolysis, catheter-directed thrombolysis, mechanical thrombectomy. All these things have to be considered. These patients need ICU admission and monitoring. Class D is full failure. Category E means emergency, hemodynamic collapse. Patient is in full failure. E1 is patient has shock. E2 is refractory shock or cardiac arrest. So we need to identify these patients and consider for advanced therapy or systemic thrombolysis or catheter-directed thrombolysis. So treatment is, as we said, D and E needs thrombolysis. Moderate, high risk, all these patients need thrombolysis. The recommended thrombolysis in patients with high risk PE. So all guidelines recommend avoiding routine use of systemic fibrinolysis in low risk PE. So what are the thrombolytic agents used? Altiplase 100 mg bolus and continuous infusion over 2 hours. Urokinase 4,400 international units per kg bolus, followed by 4,400 international units per kg infusion for 12 hours. Altiplase 50 mg for 2 hours. Continuous infusion for 2 hours. Tenecteplase 30 to 50 mg, 1 bolus. So all these are the thrombolytic agents used. And then once we thrombolize, we have to give anticoagulation. Anticoagulation usually in the hospital, in ICU, we use unfractionated heparin, can be used at a 80 units per kg bolus and then 18 units per kg per hour infusion. The risks are hit and severe thrombocytopenia. The advantage is you can reverse the anticoagulation if needed. Low molecular weight heparin, enoxaparin, 1 mg per kg subcutaneously twice daily. This is therapeutic anticoagulation. If the creatinine clearance is low, we need to modify the dose. Fondaparin X, if the patient is less than 50 kgs, 5 mg subcutaneous once daily, 50 to 100 kg, 7.5 mg subcutaneously once daily, more than 100 kg, 10 mg subcutaneously once daily. So if the patient has low creatinine clearance, then we have to be modify the dose, and less than 30 is better to avoid fondaparin X. Then the other treatment options are oral medications like rivaroxaban, apixaban, dabigatran, warfarin. All this has to be considered. Catheter-directed therapy. This aims to reduce the clot burden while minimizing the bleeding risk. So whenever we give systemic thrombolysis in high-risk patients, there will be increased risk of bleeding. So catheter-directed interventions as a rescue treatment following failure of full systemic thrombolysis are in individuals with high risk of with high bleeding risk. For example, if the patient has a recent uh, intracranial bleed, we cannot thrombolyze him with the full dose. Then we can consider these therapies. It delivers a low dose thrombolytic agents directly into the clot via multi-perforated infusion catheters. So there are special catheters which are there, which can be put in the pulmonary artery where the clot is there, and low dose thrombolytic agents can be given. Also, there are therapies like mechanical clot fragmentation, thrombectomy, and aspiration of the clot can be done. Surgical embolectomy is an open heart procedure. It is used to physically remove the large blood clots from the pulmonary arteries. The mortality is 6 to 16%. High risk or intermediate high risk patients, whenever there is a contraindication for thrombolysis or failed catheter interventions, then these can be considered. But only drawback is the surgical mortality is high. Pulmonary artery is directly inside and clot is removed. IV filters. Whenever there is a contraindication for therapeutic anticoagulation, full dose therapeutic anticoagulation, or there is failure of anticoagulation, then there is risk of thrombosis and PE. So we place a filter between the bifurcation of the confluence of the iliac veins and below the renal vein. And most of the times nowadays retrievable filters are placed where after 3 to 6 months you can retrieve these filters. So follow-up visits for 3 to 6 months after discharge. We have to use non-invasive imaging like echo, 6-minute walk test, pulmonary cardiopulmonary exercise testing to evaluate the presence of pulmonary hypertension. These patients can have chronic pulmonary embolism, chronic pulmonary hypertension. More than 6 months of therapeutic anticoagulation for primary treatment of acute PE is recommended. And beyond 3 months, for patients with persistent risk factors, we have to sometimes give beyond 3 months, sometimes lifelong. Few trials of importance. Plateau trial was published in 2014. It compared full dose systemic thrombolysis tenecteplase in intermediate high risk PE with reduced hemodynamic decompensation, and it shows that there is increased major risk of major bleeding, including intracranial hemorrhage. So for patients with less risk of less risk factors, less risk of hemodynamic compensation, so better to avoid full systemic thrombolysis. STORM PE study, it is a landmark study which showed that computer-assisted vacuum thrombectomy combined with anticoagulation is superior than anticoagulation alone. Einstein PE study confirmed that fixed dose of rivaroxaban is as effective and safer than traditional heparin or warfarin therapy. Nowadays, heparin or warfarin are Acetron is not recommended for TPE anticoagulation, and most of the times it is direct acting anticoagulations, oral anticoagulants. So to conclude, major cause of in-hospital P is the major cause of in-hospital ICU mortality. We have to be very careful, have a high risk of suspicion, pick them up if it is likely, and always make sure that you give prophylaxis. Prevention is better than cure. Thank you. I would like to know if there is any doubts or anything to discuss. Anything? Anybody has anything to say? Anything to add?
Thank you, sir.
Thank you. Thank you.
Thank you, sir.
Yeah. If there is no doubt, then we'll close the meeting. Hope this is useful. Okay, I'll share it to you, Richard. Okay, thank you all.
Thank you, sir. Thank you, sir. I'll share the record.
Yeah.